Hi, I'm Dr. Brian Kaufman, a retired family doctor and the co-founder, chief medical officer, executive vice president of the nonprofit CLL Society. Dr. Munir?
Hi, I'm Dr. Munir. I'm a hematology consultant working at St. James's Hospital in Leeds, UK, and I'm a hematologist with a CLL research interest.
Dr. Munir, at the American Society of Hematology's annual meeting and exposition, or ASH 2021, one of the most anticipated trials was one that your group was heavily involved in, and that was the GLOW trial. Can you tell us a little bit about the hows and whys of that trial and what update you presented to your fellow hematologists?
So thanks for asking about that trial. The GLOW study was primarily designed for folks with untreated CLL who had comorbidities. And this was a trial where the experimental arm combined two drugs, Ibrutinib and Venetoclax, together for 12 cycles in total, with a lead-in of 3 cycles of Ibrutinib on its own. And everybody stopped therapy after 12 cycles of combination in the experimental arm. And the other half of the trial was the standard treatment, where patients received chlorambucil with obinutuzumab. And the patients who relapsed on that arm of the trial were allowed to get Ibrutinib monotherapy. What we looked at in this trial was previously presented at EHA 2021. And it was clear that Ibrutinib in combination with Venetoclax was superior as compared to chemoimmunotherapy, which was chlorambucil obinutuzumab. And I presented the further follow-up data with the now a median follow-up of nearly coming up to 3 years. The folks who received Ibrutinib Venetoclax were responding better as compared to chlorambucil obinutuzumab, and they were not relapsing even with just fixed duration therapy, which means nobody was on treatment while this data was analyzed. I also presented the data on the minimal residual disease, both in the blood.
I'm going to stop you there for a second, and I just want to get your take. I'm going to divert for 1 second on the language, because we've been pushing the language measurable residual disease versus minimal residual disease.
Okay.
And I just wonder how you feel about that. I hear both being used now, because it just seems from a patient's perspective, it's just easier to understand measurable residual disease. I just wonder if you have just a side comment. I'm catching you off guard there. Yeah.
I think it's fine. I think as long as the minimum, I still use minimal residual disease, because this is just what comes in the papers and everything. But it is, I think we need to be clear in what is the level of disease that we are picking up. And this abstract was interesting, that it was asking the question whether we're picking up 1 in 10,000 cells, which is a CLL cell, or 1 in 100,000. So the depth of response was better, and in going up to 1 in 100,000 cells with next generation sequence. So I don't have any problems using either word, really, measurable or minimal. Yeah.
All right. And and do talk a little bit about this MRD. And one uses flow cytometry, which is the classical way in the definition, but you looked at next generation sequencing, and I think you used the clonoSEQ testing. So I'm interested to hearing what your findings were, and if you could tell us a little bit about the different testing. Yeah.
So we were looking at the measurable residual disease in both in the blood as well as the bone marrow compartment. What we found with the Ibrutinib and Venetoclax together is that the level of a measurable residual disease was much in favor of Ibrutinib Venetoclax combination. We looked at this analysis based on next generation sequencing as well as flow cytometry, but the data I presented was with next generation sequencing. Now, next generation sequencing is a much more sensitive way to detect measurable residual disease, both in the peripheral blood as well as in the bone marrow. And this is looking at some of the proteins on the surface of CLL cells that we pick up right at the beginning, and then we monitor it throughout the treatment. And it is a much better way, or a much sensitive way, of picking up any disease. So what we found in our analysis was that 51.9% of the patients achieved what we call as measurable residual disease negativity at a level of less than 1 CLL cell in 10,000 cells. But when we went deeper with next generation sequencing, we found that in the bone marrow, we could not pick up any CLL cell in 1 in 100,000 cells in about 40.6%. So in simple plain words, 2 out of 5 patients were achieving that depth of remission in the bone marrow, and that was pretty much similar in the peripheral blood. The other important finding was the results of the bone marrow and the peripheral blood were pretty similar, which means that we can do this test on the peripheral blood and would be pretty confident that we are looking at the similar results in the bone marrow as well, which will have an impact on in real world where we don't want to do that many bone marrows for our patients. So in short, we were seeing much deeper level of remissions with Ibrutinib Venetoclax combination. Next, what we looked at was the sustainability of this measurable residual disease. And by that, I mean that we had 12 cycles of Ibrutinib Venetoclax combination, and then we did an analysis on the bone marrow and peripheral blood 3 months after the end of the treatment. And then we did another analysis 12 months at the end of the treatment. And we wanted to know whether this response that we're seeing at the end of the treatment, 3 months at the end of the treatment, is sustained at 12 months as well. And it was clear that patients on Ibrutinib Venetoclax arm were sustaining that response at 12 months, what we achieved at 3 months as well. Again, we looked at another analysis that we did was looking at whether there was any clinical progression based on the minimal residual or measurable residual response with the Bruton Venetoclax combination. And one of the interesting finding was that even if the patients who had measurable residual disease and whether they achieved a complete response or partial response, still were not progressing after the short follow-up on this study. And this is something which is an intriguing finding, and we will be following up further data to see whether the measurable residual disease response will correlate with the clinical response. And lastly, one of the other findings was that we looked at the nodal response, which means the lymph node response to Ibrutinib Venetoclax. And it was very clear on the analysis that people receiving this combination achieved very, very good nodal response, and that was sustained throughout. Whether the patients achieved measurable residual disease negativity or positivity, all of the patients have had a very good nodal response, which was again an interesting finding. So to conclude, I think this combination of Ibrutinib and Venetoclax achieved very good, deep, and better sustained undetectable measurable residual disease response as compared to chlorambucil obinutuzumab. And we assess this with next generation sequencing. We don't think that the patients need bone marrows. And lastly, we achieved very good deep nodal responses with this combination of therapy.
Dr. Munir, this is, I think, really important research and suggests that the role for the chemoimmunotherapy combinations may be increasingly less going forward when we have such a great fixed duration therapy. So any final thoughts or anything you want to say to the patient community?
So I think you're absolutely right that this combination is one of the other combinations, which is going to be used in near future. I think one of the other things which I want to say, that patients who had unmutated IGHV status in this study, which is classed as a bad risk prognostic markers, were the one actually who benefited the most from this combination, which tells us that actually this is a very, very potent and good combination for this cohort of patients who have got unmutated IGHV status. So clearly enhancing our fight against CLL, especially in the frontline setting.
Let me just ask you on that, because if I recall, they actually did better than the mutated patients, which is not what we normally suspect. Do you have any thoughts on why that might be?
So I think I can just say, I can just speculate here, but we know that unmutated IGHV patients have got more proliferative CLL. This means that the CLL cells grow quickly, and Ibrutinib is very good at blocking this process of proliferation, although it doesn't kill cells. But then we do see combination with Venetoclax working in a synergistic way, which means it's a multiplicative effect rather than additive effect of this combination. So the measurable residual disease negativity rate in unmutated IGHV patient was above 60%, which is remarkable, especially it is a fixed duration therapy. So one of the thought process is that unmutated IGHV patients do benefit from Ibrutinib. We know that from multiple trials. And now we are finding that actually this combination might be very suitable for this cohort of patient group.
Thank you again for what you're doing and what you're doing in general for CLL patients. Thanks so much.
Thank you.